almost 60% of our babies had a zone 2 ROP, whereas 40% had AP-ROP. The results, the treatment success we defined as a complete regression of retinopathy and vascularization in zone 3. Primary treatment success was defined where the outcome was achieved only with a single intravitreal injection. We observed it as 75% in our series. The secondary treatment success when additional laser ablation was done, which was 25% in our series. We observed no major complications. The indication for retreatment are poorly defined. Recurrence of neovascularization or any plus disease seems to be a uniform indication for retreatment. In our series, retreatment was done at the mean age of 44 weeks, which was corresponding to the 7.8 weeks post-injection. In another study, the retreatment window was much earlier, as like 51 weeks, which was corresponding to the 16 weeks. Coming to the Rainbow trial, we had a similar outcome, like 80% of the infant achieved the same primary outcome. Coming to the conclusion, we found ranibizumab achieved a stable retinal vascularization with low rate of complication as well as fewer recurrences. It achieved similar anatomical outcome as bevacizumab without additional risk of major complication and systemic side effects. Coming to the limitation, our population was limited to the Asian patients in a tertiary eye setting, and we did not perform FFA. Here, as we can see, the ROP was resolved with a single IVR injection at 10 months follow-up, whereas the secondary outcome can be seen in second picture where the laser ablation was done. Thank you.
Thank you. That was a good presentation.
Good presentation. What was the what is the advantage of intravitreal over laser?
We allow the blood vessels to grow into zone 3, where ablation we have to do it either in a zone 2 or then ablation destroys the retina. So the field of vision and other complications are much less as compared to the laser ablation. We allow the babies and the blood vessels to grow in the zone 3. That is the advantage. And single therapy less traumatic to the patient, babies, family, everything.
Thank you.
Thank you so much.
And Dr. Kalyani Devule. Yeah.
Good morning and regards to everyone. Impact of COVID-19 pandemic and lockdown on retinopathy of prematurity practice and presentation. The world has been profoundly affected by the deadly COVID-19 pandemic. The primary aim of our study was to study the effect of COVID-19 pandemic and lockdown on the number of babies screened for ROP, number of babies detected to have ROP, number of babies detected to have treatable ROP. The secondary aim was to study the effect of the pandemic on the birth weight, gestational age, first screening and the follow-up of the babies for ROP. It was a retrospective observational study carried in a tertiary care center. The study population included NICU of 3 tertiary hospitals and the OPD patients. There were 2 study groups. Group A was the pre-COVID group of 1 year from April 2019 to March 2020. Group B was the COVID and the lockdown group from April 2020 to March 2021. The patients were divided whether they had no ROP or they had ROP in any form. Patients with ROP were divided into not treatable and treatable forms of ROP. The treatment was given in the form of laser, anti-VEGF, combined laser and anti-VEGF, and surgery. The results were as follows. Number of babies screened reduced to around 62% in the COVID and lockdown period. Number of babies in Group A with ROP were around 28% and Group B were around 26%. To our surprise, the number of babies with treatable ROP doubled from around 4.6% in the pre-COVID group to around 9.2% in the COVID group. On comparison of the birth weight and gestational age of all the babies, there was no significant difference between both the groups. Around 71% babies in the COVID period were screened on time, whereas around 55% in the Group A was screened on time. The number of babies who were lost to follow-up slightly increased from pre-COVID to COVID area. In pre-COVID area, the number of babies who were lost to follow-up was around 40%, which increased to around 52% in the COVID group. On comparison of the birth weight and gestational age of the babies who had treatable ROP, we found that there was no significant difference between the 2 groups. Most of the patients in both the groups were treated in the form of laser. On comparison with similar studies, Katoch et al. Reported reduction in the number of babies to around 38%. The surgical treatment rate increased from 1 to 3%. Bazil et al. Reported no statistical difference between the birth weight, gestational age and the number of babies requiring treatment. So, COVID-19 pandemic and lockdown has significantly disrupted the delivery of healthcare services. ROP screening was listed in the essential medical services and letters were given to the patients which enabled them to travel despite the lockdown. Number of babies screened reduced in lockdown due to cessation of public transport and routine OPD services. Many hospitals were converted into COVID-specific hospitals and routine services were shut. Fear of COVID-19 infection was always there. Treatment rate increased in the lockdown period, probably because ours was a referral center. So, to conclude, number of babies screened reduced to around 62% during the lockdown. Number of babies with ROP was similar in both the groups, though the number of babies with treatable ROP nearly doubled during the lockdown period. There was no significant difference in the birth weight and gestational age at presentation. There was no delay in the first screening of babies. Loss to follow-up of patients was slightly more during the lockdown. Thank you.
Interesting, very interesting. But what I was like, but the treatment was more.
Yeah, the patients requiring treatment was more, and the numbers who had detected with ROP was similar in both the groups, but the number of patients requiring treatment were double in the COVID.
It would have been interesting to know what stage they came in. Like,
Most of the babies were with stage 2, zone 2, stage 2 with plus disease. There were aggressive ROP patients of around 3 who were given anti-VEGF treatment followed by laser therapy, and 2 patients who had come referred to us with stage 5 ROP who required surgery. Otherwise, maximum of the patients were in zone 2, stage 2 with plus disease.
okay, so at least we didn't lose many children during.
Because they came late, they couldn't come early, or?
Ma'am, in the NICU setup where we screened, the patients were screened on time. So there was no significant delay in the screening. But the patients who were referred to our center directly might have been screened lately, and that might have caused the increase in the treatment rate.
Oh, yeah. Thank you.
Dr. Riya Sharma.
Good morning, everyone. I'm discussing an interesting case of unilateral proptosis which presented in emergency, which turned out to be sickle cell anemia. Abrupt onset of proptosis in a child is alarming sign for both the parents as well as the physician, and the differentials considered are very distinct from those in adults. My patient was a 9-year-old female who presented to the emergency with complaints of left eye proptosis and diminution of vision since 2 days in the left eye. The proptosis was sudden onset, painful, and associated with diminution of vision. She didn't give any history of recent trauma, fever, or any ocular surgery, but there was a positive history of sudden onset bilateral lower limb pain since the last 3 days, which was severe and debilitating. On ocular examination, her right eye had vision of 6/6 and left eye was 3/60. Left eye showed axial proptosis, restriction of extraocular movements, and conjunctival chemosis. There was pupillary reaction was normal, AC was coit, IDO examination revealed a normal fundus, and on systemic examination, hepatosplenomegaly was noted. The differentials of infective and neoplastic etiology were considered. On investigating the patient, there was normocytic normoclinic anemia with numerous target cells, and ESR and CRP were raised. However, the diagnosis was cinched with HPLC, which revealed a fetal hemoglobin of 17.5%, and sickle cell anemia was diagnosed. On imaging, the axial CECT showed a homogeneously hyperintense collection suggestive of a hematoma, and a diagnosis of left eye orbital compression syndrome secondary to sickle cell disease was made. On initial, the patient responded very dramatically to the first initial treatment of IV fluids, analgesics, which was given in the emergency, and there was marked improvement in the proptosis and periorbital edema within 48 hours. The patient was discharged on folic acid and hydroxyurea therapy, and there was complete resolution of the symptoms at 2 weeks follow-up. Now, orbital swelling in sickle cell disease could be due to orbital bone infarction, cellulitis, orbital abscesses, and orbital compression syndrome. Compression syndrome generally presents with headaches, eyelid edema, proptosis, and fever, and is believed to be due to orbital bone marrow infarction. Bilaterality is common. This condition is sight-threatening and necessitates a prompt diagnosis, and therefore imaging is very important. Most of these cases will resolve with conservative treatment. However, surgical exploration is needed in certain severe cases. Thank you.
Interesting case. Did you mention what the optic nerve looked like? I didn't see. Sorry.
I mentioned that the optic nerve was normal. There was no evidence of the pupillary reaction was also normal, and optic nerve had appeared normal.
But then why was the vision 3/60?
Sir, the child actually, due to the edema, the chemosis, and the pain the child was experiencing, was able to tell 3/60 at that time.
How is the pupil?
Pupillary reaction was normal, there was no RAPD noted.
No, but then that is a little contradictory, because if there is that, I mean, I'm not really convinced about the reason that you're saying for the low vision.
Yes, sir.
Because if the optic nerve, so only thing that I could probably think of is the optic nerve compression, if
Yes.
at all.
Yes.
3/60 can't be a vision that can arbitrarily say that the patient could not appreciate,
Yeah, yes.
is what I'm thinking.
But
And then what
since-
happened to the vision after resolution of the edema?
Within 48 hours, she was able to read up to 6/9, and then after follow-up at 1 week and 2 weeks, we
Full
examined 6/6 vision.
Okay.
Because compression and other thing is a toxic type of perineuritis or something, but the pupil should have been affected.
Affected, that's right.
Anything in the cavernous sinus?
No, it was normal.
Okay,
Thank you.
thank you. Can Dr. Eva Rani Kalita come in, please?
Good morning, everyone. So myself, Dr. Eva. I'm going to present the study of referral pattern in Pediatric Ophthalmology Department in a tertiary eye care center of Southern India, the REPO study. Blindness remains a major health and social issue in India. Childhood blindness has larger social impact when Delhi is taken into account. Access to the tertiary eye care becomes way more difficult when pandemic situation like COVID-19 hits the world. It's of utmost importance to make every clinician who is the first reach to this population aware of the red flag signs a child might present to them seeking primary care. It's also important to make them identify the embryogenic risk factors and urgently refer to the concerned subspecialty department. So keeping these things in mind, we had the purpose to evaluate the referral pattern to Pediatric Ophthalmology Department in a tertiary eye care center of Southern India in terms of visual acuity assessment, disparity in diagnosis, and delay in reporting. The visual acuity assessment was considered inconsistent if more than or equal to 2-line difference was found when measured in the tertiary center. Disparity in diagnosis was when the final diagnosis didn't correlate with the diagnosis of referral, and delay in reporting was counted when more than 14 days lag was noted from the date of referral by the primary clinician. So it was a retrospective study done for 6 months duration in 2019 in a pediatric age group of 0 to 16 years in the Pediatric Ophthalmology Department of Arvind Eye Hospital, Pondicherry. So we had 77 referrals in this time period. 6 patients were excluded from the study because the records were incomplete. We divided the study group into various age groups like infant, preschool, school-going, older children, and adolescent. So out of the 71 referrals, we found that most of the referrals were by the ophthalmologist, followed by pediatrician, and among others were the cardiologist, pediatrician, general practitioners, and neurologist. The visual acuity assessments showed that only 16 out of 54 children referred by the ophthalmologist had visual acuity mentioned, and they had 75% accuracy of the visual acuity. Diagnosis discrepancy showed that 38% of total patients referred had diagnosis discrepancy, and interestingly, 27% discrepancy was noted in the ophthalmologist referral alone. Delay in reporting was counted for the patients who had some kind of medical or surgical emergency, or the patients who had embryogenic risk factors like squint, congenital cataract, ROP, and isometropia. And we found that 17 patients out of 51 referred were having delay in reporting. So from this study, we concluded that most referrals in pediatric ophthalmology were apt with appropriate visual acuity, but 1/3 of referral had inaccurate diagnosis, and almost half referral in the embryogenic group requiring immediate evaluation were found to be delayed. So proper counseling to the parents by primary eye care providers, emphasizing the need of immediate evaluation and intervention is of utmost importance. There is also need of creating awareness and guidelines for appropriate referral to subspecialty clinic in ophthalmology. Thank you.
Yeah. Which were the cases which were mostly diagnosed wrongly by ophthalmologist?
Ma'am, thank you for the question. Most of the patients who had pseudoconvergent squint, they were referred for infantile ETs.
Okay.
Yeah, ma'am. And patient with squint, they were referred for squint, but they were having some cataract, like developmental congenital cataract, and they developed strabismic
Sensory type
sensory
of-
deprivation amblyopia
Okay.
or squint. And Interestingly, the pediatrician used to refer for senile Leo, but 2 or 4 patients were having membranous conjunctivitis or pseudomembranous conjunctivitis.
Okay.
Like that, ma'am.
Yeah, interesting study.
Interesting study. We're just wondering, it's just 38%. That's what we were discussing. It's just 38%. So how do, because you're all youngsters now, how do you plan to increase it?
Yeah, ma'am, we have already started our. We have already
You need to
started-
increase it.
We have already started. Like Arvind Pondicherry is located in an area which is surrounded by most of the medical institutions, ma'am, like private medical institutions and some subspecialty hospitals. So we are creating awareness by calling them for workshops or CMEs or like distributing pamphlets mentioning at least these are the child's condition that you have to see or the red flag signs. At least they can do a direct ophthalmoscope Bruckner test to identify the leukocoria, white reflex. They can see at least to identify some of the major morbidities in children.
I think you should go to them and do the workshops. Nobody
Yeah.
comes for the CME sometimes. Even the pediatricians don't turn up.
Yeah.
You should go there and at least tell them to do. Tell them it's legally bound. That it is important to detect, because when they send and we say it's a cataract, then they say, oh God, the pediatrician ne dekha kyun nahi? Then they ring up the
Interesting,
pediatricians.
ma'am, the pediatrician referrals were more in a formal way. They mentioned more details about the children. Like these are the conditions we want to know.
That's okay as long as they refer.
Yeah, that, ma'am. And actually, we saw that most of the population they have the lack of information that we also have the subspecialty departments in ophthalmology right now, because the pediatrician itself didn't know that we have a pediatric ophthalmology department in ophthalmology.
Okay.
So that awareness we have to create, I think, ma'am.
That is interesting.
Yeah, that's what. Thank you so much.
Thank you.
Dr. Naina? Is Dr. Naina here?
I think hers is not right.
It's not ratified, but she can still present.
Yeah.
She's not here.
Okay,
so-
Dr. Ravindra? Yeah. It's an interesting topic.
Yeah, I was interested in knowing innovation has been done.
Yeah. Yesterday, this paper was presented. In the yesterday's free paper session, it was presented as a paper by someone else. By this Deepika.
Microcornea, cataract, secondary glaucoma, comorbidity is a situation where glaucomatous optic neuropathy may already be present or may follow up after the cataract surgery. And there is the additional challenge of selecting an optimally selected sized IOL for the visual rehabilitation without adding to the risk factors of progressive damage. This was one of the cases which we saw in one of the earlier sessions. Recurrent uveitis, secondary glaucoma, UBM showing the vaulting at the haptic-optic junction, and that was a contributing factor to the shallowing of the anterior chamber. What we did on table is to modify this Rayner model IOL. Actually, why this idea came to me was we have seen many of the Rayner model IOLs breaking during our adult cataract surgeries. And we used to leave them if IOL appeared to be centered. Then I thought of this particular case where IOL was posted, and I thought why not try to measure the wide-to-wide diameters of IOL and eye, and then I thought that this will fit well enough. And this was not the first case that I got photographed. This was the third or fourth case actually, over a period of 5-6 years. First I think I did in 2014. And this was 2019, and we presented it in IPGS Pediatric Glaucoma Conference also as a poster. And this photograph shows the detailed aspect, how the haptic has been within the bag and safe. And this was a pupil dilated stage, and PCO developed, and of course we treated it later on. And this is the diagram showing the correspondence of IOL, means this part of the haptic is visible in this part, and this is the corresponding UVM picture of the same eye. So antechamber is well maintained. And this modification can be readily made during the surgery and may be considered as an option in selected cases of microcornea for visual rehabilitation. And in fact, in the adults also, when sometimes the phagomulsification creates shallow AC and iris prolapse, in those cases also this may be used. I have used it actually. Of course, CTR was also used along with that because that particular case had some situations. Thank you, sir. Short presentation.
So how many cases in pediatric is it?
I had done 4 cases actually.
In
so
pediatric cases.
far.
And what is the follow-up like? How long?
Follow-up, none of the patients developed any secondary glaucoma or
Over how much period?
means exact follow-up is not there, otherwise I would have presented the data. But this particular case I have got long follow-up, more than 6 months.
Okay. It would be interesting to know the follow-up because
Yeah.
what happens whether it's get decentered because long-term,
Yeah.
because when, especially in the children when the bag is,
Yeah,
contracted, called
fimose.
fimose, what happens to the... Anyway, good idea, very nice idea.
Photograph you showed also had some degree of decentration.
Yeah, this had been, that is why I wanted to show that
yes.
particular case as it is.
Because that is the problem we face when one of the haptic
gets
optic
cut.
breaks off while injecting the IOL in adults. We have to remove it for decentration.
So if the CTR is also implanted, maybe zonular dialysis weakness, that part may be taken care.
No, even if not with the
Capsule.
zonular dialysis, with
Because
the
of the
intact
haptics.
zonules, because you're reducing, it is meant to be 13 millimeters.
Yeah.
If you're reducing it to 9 millimeters, of course in microcornea it could be, it may not be a problem, but in adults it definitely would be a problem.
And it was a 10 mm that you mentioned, not lesser than 10 mm.
Yeah.
Horizontal corneal diameter.
Yeah.
And can the cut edge be traumatic to the capsule or something?
If it is within the bag, it will be safe. It won't be. In this particular case, we were lucky enough to see it through the pupil.
And it's a good innovation.
But how are the edges? Are they smooth or
Yeah,
they
yeah. I
remain?
saw it under the microscope after the cut. Haptic was before taking the final decision to implant.
Okay.
And then no pupillary block or anything like that?
No, after this, patient had.
Great. Thank you so much.
Just a caution to all, when there's anterior segment dysgenesis in small babies, like say less than 1 year, or it's better not to put an IOL because it is not, because chance of secondary glaucoma are very high. So if you find that this cornea is very small and on UBM you find that there is, the anterior segment dysgenesis, like there is attachment of the iris to the cornea or angle anomalies, preferably, especially in small babies like 1 year or 2 year. It's not we don't need to be heroic to put an IOL, okay? Because I'm just saying a word of caution. All our youngsters here, so.
Yes.
Yeah.
Yes, sometimes it is better to do less than to do more.
Dr. Divya?
Good morning, everyone. The title of my study is Choroidal Thickness Measurement Using Enhanced Depth Imaging OCT in Pediatric Population. Now, choroid, being the most vascular tissue in the eye, plays an important role in pathophysiology of various ocular conditions. And newer imaging techniques like Enhanced Depth Imaging OCT has improvised the visualization of chorioscleral interface, which helps in detection of the choroidal thickness clearly. The eyes of healthy children differ from those of adults, and the influence of a normal developmental process on the choroidal structure can be evaluated by determining choroidal thickness in children of various age groups. The aim of this study was to measure choroidal thickness using EDI OCT and to see its variation with increasing age and with different refractive errors. The study was spanned over a period of 1 year. It was a cross-sectional study and it included 300 pediatric patients, that is 600 eyes. All children walked-in patients in the pediatric OPD from 5 to 18 years with or without refractive errors were included, and all pathological eye conditions were excluded. Complete ophthalmological examination was done and choroidal thickness was calculated manually from the external surface of RP to the chorioscleral junction under the fovea, as shown in this image, where we drew a perpendicular line under the fovea from the hyperreflective line. Hyperreflective line suggests the retinal pigment epithelium, and it was extended up to the chorioscleral junction, which is clearly defined in the ADI mode. So we found that the mean choroidal thickness in Indian population in this study was 378 micron, and the association between choroidal thickness and age was clinically significant with a negative correlation. When coming to refractive errors, the association of emetropia and choroidal thickness was also clinically significant with negative correlation. But in myopia, though the correlation was negative, but it was not clinically significant in this study. Comparing other similar studies, Tenlik et al. In the Turkish pediatric population found the mean subfoveal choroidal thickness to be 388 microns. Bidot Garner et al. Found it to be 341 in French pediatric population, and Park et al. Found it to be 348 microns in Korean pediatric population. The mean choroidal thickness in our study among emetropes were 415 microns, which was higher than that in myopes, that was 372 microns, clearly suggesting that myopes had a thinner choroid, and no association could be established between choroidal thickness with hypermetropia or astigmatism in this study due to limited number of subjects and unequal distribution among each set of refractive errors. So to conclude, the mean choroidal thickness is more in younger age group. The choroidal thickness is correlated negatively with age. When seen in emetropia, it also has a negative correlation with age, but in myopes, though being negatively correlated, we did not find a clinically significance in that because myopes have a thinned out choroid and it does not get thinner with growing age significantly. And no association could be established between hypermetropia, astigmatism and choroidal thickness. Thank you.
Did you see any association with amblyopia?
Ma'am, amblyopia we excluded.
Okay.
All
Myopia.
Myopia, she
myopia
told
was
us.
clinically, there was a negative correlation, but there was no clinical significance found in this study. The children with myopia at 5 years were also having a thinner choroid, and 15 years also had a thinner choroid. So there was no.
Compare, but you didn't take anybody with LDA, with low dose atropine, no.
No, ma'am.
That would be interesting. After this, you do that and see
Okay.
what happens to the choroid in the same. This will be your control group. At least age match to see what happens when the patient is on low dose atropine.
That'll be interesting to see.
But this is your same control group. You could use this as.
Great. Nice presentation.
Thank
you. Okay, now Dr. Shalaka. You got here in time. Huh?
My study is the study of persistent ROP requiring laser in a tertiary eye care center. According to ET-ROP, type 2 ROP which persists beyond post-menstrual age of 45 weeks is known as persistent ROP. Type 2 ROP according to the ET-ROP trial does not require any treatment. This persistent ROP presents a dilemma for the ophthalmologist as there are no clear guidelines for such cases. The aim of our study was to determine the frequency of persistent ROP and describe its characteristics. A retrospective review of preterm babies who were screened for ROP from 2015 to 2021 was done. Persistent ROP babies were identified and defined as stage 2 or 3 ROP without plus disease, which persisted in zone 2 or 3 beyond 45 weeks of postmenstrual age. These babies then underwent ROP laser to the avascular area anterior to the ridge. Results: among the babies screened, about 0.5% of the babies were identified with persistent ROP with mean gestational age of about 30 weeks, birth weight of 1191 grams. The post-conceptional age at which these babies underwent ROP was 47.33 weeks. The highest stage attained was in the maximum number of eyes was seen to be zone 3, stage 2 in about 47%, and the number of days from the highest stage attained to doing of ROP laser was around 75 days, with reactivation seen in about seen in none of the eyes. In discussion, there were about 3,596 babies screened, out of which 18 babies were seen to have persistent ROP. This incidence rate is similar to other studies which were conducted by Liu and Tomlinson and Gupta M et al., where the incidence was seen to be 0.5 and 0.2%. So this incidence is much lesser than treatable ROP. This shows a relatively uncommon and rare occurrence.
The mean gestational age and birth weight was also similar to other studies which were done, such as those done by Rajan R. et al. And those done by Kaucheki R. or Isaac M. The gestational age at the time of treatment, that is laser, was similar between the studies between our study and that done by Rajan R. et al. That was 47.5 weeks. So untreated ROP, as we know, shows conditions like atrophic holes and retinal tears up to late age of follow-up. Also, vitreoretinal fibrosis associated with ROP has increased risk of tractional retinal detachment. Peripheral avascular retina in treatment-naive or post-bevacizumab eyes may have risk of retinal detachment later. So in our study, the decision whether to treat or no when to treat was taken by senior pediatric ophthalmologists with more than 12 years of experience. There were other criteria for treatment, such as stage 3 ROP in other studies, such as stage 3 ROP persisting for more than 6 weeks, or straightening of temporal vessels and greater than 2 clock hours of persistence of stage 3. This condition represents a special population which can benefit from further studies and studies for need, effect, and timing of intervention. In the study done by Rajan R. et al., one baby having persistent ROP was seen to have treated with intravitreal bevacizumab and no recurrence of ROP was seen. So this presents an additional possible indication for intravitreal anti-VEGF agents for persistent ROP, where we can do away with the adverse effects of laser. However, we need further studies with larger sample size and which compare those babies who were treated for persistent ROP versus who were not treated to determine whether treatment is actually needed in these studies. The limitations of this study were, in our study, we did not measure factors such as rate of growth of retinal blood vessels or systemic factors such as weight gain and hemoglobin, the correlation which would have had some weightage on the persistence of ROP. The criteria for persistent ROP is not standardized. Comparison of treated and untreated patients would have been better, and fundus fluorescein angiography would have been a better guiding tool. In conclusion, persistent ROP requires longer follow-up, and laser photocoagulation leads to good resolution of the condition.
You have screened about 3,500 babies, and what was the time duration?
Ma'am, around 6 years, ma'am, 2015 to 2020.
6 years, okay. Yes.
Thank
you.
Means, good study because you took a large number of cases, a retrospective study. So it was good. But what was different compared to the other studies in the world?
Ma'am, actually, this was basically a multi-center study. There were around 4 to 5 centers involved, ma'am, in this. And we were basically not trying to measure treatable or untreatable. We are trying to see what was like the persistence of ROP beyond 45 weeks of post-menstrual age, where we actually had to treat the babies. That's what we were trying to see. We were not trying to see whether treatable or non-treatable is.
Okay. Thank you. Dr. Henal Zaveri.
A very good morning to everyone. IOL implantation is one of the most satisfying advances for an ophthalmologist, and modern cataract surgery cannot be imagined without it. But while in the earlier era, the keyword was implantation, currently there is a new keyword on the block, that is opacification. So I present to you material analysis of 3 opacified hydrophobic acrylic intraocular lenses. There were no financial interests. IOL exchange has been estimated to be 2 per 1,000 surgeries. The leading cause of this is IOL explantation due to opacification, which is largely attributed to primary calcification, that means due to the inherent property of the biomaterial. This is a complex phenomenon, and the chemical and physical changes due to this could be reflected over the surface of the polymer. With this in mind, we analyzed these IOLs, did the light microscopy, scanning electron microscopy, and energy-dense spectroscopy. 3 IOLs were explanted due to reduced visual function in the late postoperative period. Light microscopy was done and they were transferred to the Center of Nanotechnology for energy dense spectroscopy and scanning electron microscopy. The age ranged between 64 to 80 years of the patients, and the duration of pseudophakia on an average was 11 years. All the patients had visual acuity from 20/40 to 20/80, and all patients had visually significant glare. Medical history of all the patients was unremarkable. So as you can see, on light microscopy, in sample 1, the center of the optic was opacified, sparing a peripheral ring, which was under cover of the anterior capsule. On scanning electron microscopy, that is the figure in the center, you can see surface erosions and cracks, while below is the control specimen, which showed a smooth and homogeneous surface. In figure 2 also, the optic was hazy and cloudy. The surface had a conglomerated appearance with central pores. On higher magnification, the surface had crystal deposits. All the samples, as represented by the energy dense spectroscopy image below, showed absence of calcium and phosphate peaks. Sodium chloride and silicon peaks were present. Sample 3 also had opacification of the optic, and on scanning electron microscopy, surface erosion with licking of the surface is seen. So basically, we postulate that the degradation of a polymer in a biological environment results from hydrolysis or enzymatic attack. When they are present for a prolonged period in vivo, water gets absorbed, resulting in chemical hydrolysis, making the polymer unstable, resulting in surface erosion. This surface erosion produces cracks and pores, and when light passes through this, it gets scattered at every point of refractive index homogeneity, giving an opacified or hazy appearance. The absence of calcium and phosphate peaks in our specimen was observed, and collaborating that with the findings of the electron microscopy, we believe that post-operative opacification is seen due to long-term degradation of these IOLs. Why am I presenting this here? Because this will be most relevant to pediatric ophthalmologists operating on pediatric cataract patients with the highest pseudophakic life. And therefore, we must be vigilant, and further research on this subject is required. Thank you.
Very nice.
These are my
Yeah,
references.
very nice, yes. So you didn't find any calcification as such? It
Yes,
was
ma'am.
just degradation of the
Yes, ma'am.
polymer?
Correct.
Okay. Recently, I had to explant an IOL operated somewhere, and it had become like the vision had reduced to PLPR. It was that bad.
Yes, ma'am.
So it was looking like a
Pediatric
mature
age?
cat. No,
Acha.
adult patient.
We've actually carried out a study on
I tried to get the histopathology done of that IOL, but no one was ready to do here in Nagpur.
We've actually carried out studies which for primary calcified IOL as well, where we've proven that there was calcification. Their scanning electron microscopic features are quite different. The surface has a millet seed-like appearance on scanning electron microscopy. And this has a very different appearance with cracks.
Any expiry ka date or something like anything you found, like where maybe those IOLs were, because sometimes the power of the lens when it is, say anything on the power of the lens,
Ma'am,
like whether it is like these low, like 10 diopters or 15 diopters where they keep the lenses. Anything you found like that?
No, ma'am, there was no such association of a high IOL power or even expired IOLs. No.
Means you checked it? Like
Yes, ma'am, we have looked into it.
The packaging style of the IOL also can lead to calcification.
Yes,
If
ma'am.
it is not done properly, the packaging style of IOL also can lead to calcification.
Yes, ma'am, absolutely. There has been studies which have reported that it's either the packaging or the polymerization process, which is not uniform, which results in this, which predisposes the IOL to such conditions.
Was this hydrophilic or phobic?
Phobic.
All these were hydrophobic, sir. Yes, ma'am.
And that is scary because all in children we are putting all hydrophobics.
Yes, ma'am.
Yeah,
Then,
hydrophobic. So if
were the brands known? The names of the...
no, she can't say that.
She can't say that. Maybe you can tell us outside the hall.
Anyway,
Absolutely.
yeah.
Were they the same brand, all three?
All three were the same manufacturer and make model.
Okay.
Yes, ma'am.
I'm sure they were imported. Thank you so much. Very nice study. Yeah, so we come to the last one, Dr. Tithi Kundu. Nahi hai?
Oh, thank God.
Record break time, huh?
Yeah, you go. Yeah. You signed it, no? Yeah.
See you, ma'am.
Bye. See you. Yes. Please come. Suma.